Right. Um, well, telemedicine is on a lot of our minds, and it's really a topic of conversation that are very important to the people that are attending the virtual summit. And today I'm excited to have a special guest to have a deep conversation about that. And I'm excited that we're able to sit down. Welcome.
Thank you. Thank you. It's great to be here.
Do you mind sharing a little bit about yourself, your background, and share, what role you play in your current organization?
So my background is, for many years, I was working with small and early stage companies, a number of startups, all in healthcare. The last three were focused on using healthcare data to help consumers navigate the healthcare system. So I think that in saying that, it's acknowledging that healthcare has always been a little bit complicated for us. And I then decided to move to DC from Chicago, where I'd spent most of my career, and ended up getting recruited to run the ATA, the American Telemedicine Association. So I've been with the organization just over 2 years, and as they say, timing is everything. It's just an incredible opportunity we have as an industry, and it's really an uncommon time that I think we can use to everyone's advantage, especially Americans.
Yeah, you might say they're unprecedented times that we've been living through, and
Right.
it almost, I hear a lot of people refer to the pandemic as opening up the era, or maybe even the golden age of telemedicine. So let's talk a little bit about the current state of telehealth and telemedicine in the United States.
Sure. So I think and everyone who's listening knows that the amount of activity in telehealth has been, as you said, unprecedented. I mean, we're looking at data on utilization that showed between the beginning of the year up until week 17, I mean, the surge was enormous, 11,000% increase in Medicare, I think it was. And particularly if you look at the same period of time over last year. But what's interesting now is that the utilization has dropped, and it's not as high as it was before. It's not as low as it was before. So you're seeing it average out to about 30 to 40% of what it was at the peak of the pandemic, which I think is interesting because once we get past all the conversations about the boom and the surge and the amount of activity that happened, we're going to start drilling down into the data of what worked and why that was important and what made a difference.
Yeah, I've heard, I've often heard it being equated to the Gartner hype cycle, and that there was a little bit of a hype around the pandemic, and then, and it's been a drop off. And a lot of that may be based on how consumers are, viewing the platform, because we know that there's many key stakeholders, but the consumers, patients, are the actual users of the platforms. So do you mind, let's take a few minutes to dive into the perception that we're finding from people that are using these tools, because telemedicine's not new. It's been around for years, yet it's being utilized, much more lately. So what have you seen?
So I think it's safe to say that pre-pandemic, when I joined the ATA, although the tools and resources that were available to people, had been available for over 25 years, the uptake by both consumers and clinicians was quite low and well under 20% of the available population. And so what happened was that a lot of utilization was done by consumers on direct-to-consumer products, and these they could access either through their health plan or through their employer. But there was also a growing number of digital-first companies that were out there that were providing telehealth to people who really appreciated the convenience, the ability to just text or communicate with their physician when they wanted. And of course, there's always the example of Kaiser that was using it quite pervasively. But what we found during the pandemic, number one, is that consumers were frightened. They didn't know where to go. They didn't know if the symptoms they had were related to COVID. And so what they did was that they ended up using telehealth because they were told to stay away from the emergency room. And a number of delivery systems, actually put in place chat first or interactive assessments for consumers so they could screen themselves and basically figure out whether or not they had symptoms that were consistent with COVID. And I think, those telehealth tools, which is what they are, really saved a lot of delivery systems. It enabled them to scale in a way that they hadn't before. And so that was really quite remarkable. From a consumer's perception, I think pre-pandemic it was very much, for many consumers, it was a convenience factor. It was for consumers who were, had better income, for example, because they had insurance products. And we can talk about some of the limitations of telehealth pre-pandemic with Medicaid populations. But then during the pandemic, what we found was that there was, people were pleasantly surprised. I mean, there's a great study that the Hartford Foundation did with older Americans, 70 and older, who were using telehealth for the first time. And honestly, they thought it was as good, if not better, than face-to-face. And this is coming from an older population. So I think people were pleasantly surprised. And I think what we're going to see going forward is that consumers didn't understand how they could use it. We always knew from the research that if they were encouraged to use it and they used it, they would be very happy with it. But now they felt like they had to use it because they didn't have any other choice. And then what they did was they did use it and they were pleasantly surprised. And I think that what we'll find is that as we move forward, if it's taken away from them, I think they're going to be, quite frankly, indignant. So we're working to make sure that's the case.
Yeah, I kind of colloquially call it that the telemedicine toothpaste is out of the tube now, and we all know how to use these tools. And I think that's reflective of all the other digital tools in our lives as consumers now, right? Now that we're using Zoom and doing these virtual conferences and things as well. But on the other side of the screen, there's also an important stakeholder that's part of this conversation, which are those providers that are actually providing, their services through these platforms. And I'd be interested to hear from you. Prior to the pandemic, there was a great resistance about introducing these tools or using telemedicine as platforms. How do you see their perspective has changed?
So I think that the resistance, as you called it, was not consistent across the provider population. And again, I think what we've learned is that, number one, providers in some instances felt like they were not properly trained, that they were not properly equipped to do telehealth, and that in many instances they had to make it up on their own. But then you have systems like Providence and Intermountain and Avera eCare that are really focused on doing telehealth. And they were part of that cohort that just rolled out hundreds and thousands of physicians within a small period of time and did it very well. You have physician practices that likewise went from in-person, face-to-face to virtual over the course of a weekend. And they are likewise very surprised at how well it's went. So I think that we owe it to providers to make it as easy as possible for them. We also owe it to them to ensure that they have the support, the training, that they're using the right resources. We know that during the pandemic, there was a relaxation of enforcement of HIPAA guidelines, and as an association, the ATA feels really strongly that that's, we're very concerned about privacy and data security and confidentiality as our providers. So we want to make sure that those sort of waivers and relaxation, if you will, of the regulations don't stick. But I think the other with the providers is that, it varied by practice, by, specialty. There were some practices that had been very much virtual prior to the pandemic. So again, it'll be interesting to see as we go through the data what has held true versus what hasn't.
Right. Yeah. And I want to get into, the kind of the expansion of the utilization of telemedicine, because I think that's an important differentiator. Because you're right, I worked in a health system for many years, and we always thought telemedicine was sort of like the entry point, right, into the health system, and that would refer into a primary care. Yet I see now that many organizations are starting to think about this in a more holistic way, even expanding telemedicine into their care pathways for very complex service lines like oncology, cancer treatments, cardiology. Are you seeing the same?
Absolutely, and I think the bias that we've had historically is getting shook. And in other words, we cannot think of it as the front door. We have to think of virtual services as meeting consumers where they are and helping them access in whatever way makes the most sense.
Mm-hmm.
And so with care management, with companies like Livongo, which just yesterday it was announced that they were acquired or merged with Telehealth, we're seeing that sort of engagement with consumers and meeting them where they are is something that we know holds true for any other sector, any other industry, and we can make it work in healthcare as well.
Yeah, absolutely. And I think another bias that we might have had is that the usage of telemedicine to reach, let's say, disparate rural areas in certain geographies, that was a really good application of these tools. Yet, I think the pandemic has proven as well that you can actually connect more effectively with people that are right in your own backyard. Isn't that true?
Yeah, I think that one of the things that we miss is that prior to the pandemic, we had an enormous problem with access in the U.S.
Mm-hmm.
And there was huge variation not only in access, but in cost and quality. And so your geography was very much your healthcare destiny. And what happened is that was just shown to be amplified, and the toll of it was much more dramatic than any of us had ever anticipated, or perhaps many of us had anticipated. So it's incumbent on us now, as we think about the waivers and the things that need to change in terms of regulation and legislation, the first thing that we have been advocating for is the elimination of the originating site. So this idea that you cannot discriminate against providing services based on where someone lives, I think is the best way to put it. And because we know pre-pandemic that, as you suggested, Chris, there are a lot of medical deserts out there in the middle of Chicago or Washington, D.C., and you think of a mom trying to get her child to a clinic, and it takes a couple of bus rides and a transfer and so forth. That's onerous. Mm-hmm. So I think that's something that has really, the visibility has really been raised, and quite frankly, it's going to be incumbent on all of us to help change that.
Yeah, absolutely, absolutely. Another thing that I see as maybe sometimes confusing or muddling the equation here is there's this entrant of many of these retail, as you mentioned, retail third-party organizations that are applying or providing telemedicine, Teladoc and Livongo being, two great examples of those. And that can potentially be seen as like a different type of telehealth than one that you might get from your health system. What are you seeing in terms of the differentiator between retail versus maybe a health system delivered telemedicine?
Well, I think that what's happened is that the retail providers of services have really taken a page from the marketing handbooks of the best and the most successful companies out there. And again, it's this concept of making it very easy for people to interact with them. You see that particularly in the direct-to-consumer asynchronous companies like Hims and Hers and Ro, where it's just very easy. And they're doing medicine and healthcare differently than perhaps the way we've been steeped. So I think that what we're going to have to acknowledge is that, first of all, it's going to be up to the clinician and the patient in terms of what's the best way to treat them, and make that readily available so that we deal with issues of connectivity and broadband, and not only have the ability to connect people, but to give them the equipment to do so. Mm-hmm. So again, when you think about how many people, Medicaid populations, 95% have a phone, and yet because of some arcane regulations from the Consumer Protection Act, you can't proactively text them. That needs to change. Mm-hmm. So, Medicaid providers plans need to be enabled differently than they have been.
Yes, certainly. I mean, these digital health tools and the equity around accessing these digital health tools is a critical piece of this. And while the technology has evolved and rapidly evolved and accessible to many of us, it seems like the regulations themselves need to kind of play catch up. Is that fair?
Right. No, that's absolutely true. And I think the other thing that happened during the pandemic and is still playing out is we've historically talked about the need to reimagine care and use technology to do more than replace a face-to-face visit. And nowhere has that been more evident than the whole movement to remote care and remote monitoring. and the use of technology to help people stay at home, or their home as, I think it's hospital shifts to the home, as Phillips talks about it, or even, companies that provide home care like Matrix Medical. What they did was shift their business from in-person to virtual over the course of the pandemic in a very short period of time, because people were afraid to leave the house. They didn't want strangers who they didn't know whether or not they were exposed to the virus. So remote monitoring has just been an incredible godsend, and I think we're going to see a lot more movement with that.
Yeah, absolutely. Well, so it would be remiss of us not to talk about some of the perspectives of the people that are listening and watching us today, which are the marketing and communications professionals that are within the health systems. And so if you're comfortable, I'd love to talk a little bit about how do you feel the role that marketers and communicators, and this could include physician relations, can play in helping to maybe shift the perspective and adoption of these tools?
Well, again, you have to make it easy for people to access them. So one thing that we've become very aware of and very sensitive to is the notion of, not everybody speaks English. Mm-hmm. And if they're Spanish speaking, there are different variations or cultures surrounding that. And of course, you have California and other parts of the country where you have large Asian populations. So being able to communicate with people readily in their language, I think, is something that health systems have struggled with and they'll continue to struggle with. I'd like to think that technology is going to make it easier for them going forward. The second thing is that, again, this is a bias of the industry in terms of physicality. So we have this idea, I think clinicians and consumers, many of them, or some of them at least, believe that you have to lay hands to understand what's going on with someone. And yet you also have clinicians who will say that 70% of what they need to know they can get through an audio-only consultation or audio video. So I think that's interesting and something that we're going to have to acknowledge in how we talk about and how we pursue relations from a community-based perspective. And then the third point I'd make is that we have an edifice complex. We like our buildings. We want them to be fantastic. And I bet Neiman Marcus like their buildings too, but that's changing. So I think that, this whole experience between people giving and receiving services is under an incredible transformation. And I think, quite frankly, the marketing communications folks at delivery systems are going to be critical to understanding what the needs are in their community and how to best reach them. I think it's an exciting time. I think it's scary, but I think it's also exciting.
Yeah, and I also believe, and help me, correct me if I'm wrong, there are multiple different types of now telemedicine solutions available, and it's not like sort of a one-size-fits-all. You mentioned some remote patient monitoring, virtual consults, chats, they're asynchronous. And I think that helping to maybe outline and navigate and share with the various audiences, the consumers, patients, which are the best solutions. Is that fair?
Sure. So I think that, first of all, when I started with the ATA, I think telemedicine, telehealth had sort of definitions that were at a level of specificity because of regulations and legislation that were lost on most of the population. And so we set out to really broadly embrace the notion that when services are provided from a patient to between a provider and a patient, or even a consultation between a provider and another provider, and they're not in the same place and technology facilitates that, that's telemedicine as far as I'm concerned, or telehealth. So it's telehealth, telemedicine, digital, virtual, MP, digital therapy. I mean, it's the whole enchilada, if you will. And so I think that what we've found is in that broad definition that you have things like asynchronous, the fact that people are using chat or some sort of interactive assessment. You have synchronous, which is what we're doing right now. And also synchronous includes audio only, which has proven to be very effective for many populations, particularly those that may only have bare cell coverage and no Wi-Fi at all. And then remote monitoring, which again saw some real progress at the end of last year because of the new codes that had been released. So remote monitoring, again, being able to assess a patient's state without actually laying hands on them or laying eyes on them and allowing them to stay home. I think the other thing that's been very interesting is the whole use of AI in this. So we know that AI has powered a lot of this in terms of decision trees that help interact, help exchange go faster or more accurately. But you also have really proven applications, for example, diabetic retinopathy. And that didn't happen during the pandemic. That happened pre-pandemic. And so I think that, again, telehealth or virtual health has historically been considered second-class medicine, perhaps, in many circles, and that's just not the case.
Yeah, it certainly has. I mean, as our lives have changed with this pandemic and forced us to become more virtual, just like we are today, it's provided an ample opportunity for the various solutions to come to the forefront and really empower and improve the way we deliver care. Is that fair? Yeah.
Well, yeah. It improves our ability to deliver care. And again, pre-pandemic, we did not have enough clinicians. The example I often use is telemental health, where a majority of counties in the U.S. did not have mental health specialists, and yet we knew 1 out of 5 Americans had a mental health issue. So the best way to deal with that is behavioral health delivered virtually. So again, and that's been proven true with the pandemic.
Yeah, absolutely. Well, I know that the organization that you're a part of, the American Telemedicine Association, is an incredible resource of information that I've learned a lot from by participating, not only in conversations you've been on a number of other podcasts and other things, but can you share a little bit more about how ATA, the mission, and how people that are listening in maybe can participate and learn more?
Absolutely. Well, we have been very busy on the policy and advocacy side as well as on tools and resources, because as an association, there's a lot of value that we can provide to our members across a number of different dimensions. So on the policy and advocacy side, I'm pretty sure a number of your listeners signed on to a letter that we helped pull together with a few other stakeholders that was to congressional leadership. And what was unique about that letter was 2 things. One was 340 organizations signed on, which is pretty significant. And then the second thing about the letter is that we had 4 specific asks. So there was no platitude, pablum, none of that. It was, these are the things that have to happen for us not to go over the telehealth cliff. And we're going to continue on that front and have launched a campaign as an association with many of our members and partners to ensure that the gains that we've made stick. And that's at the federal level as well as at the state level, because there's a lot that takes place at the state level. And then likewise, the tools and resources. We basically opened up our treasure trove of resources, practice guidelines, how to do certain things well, how to do them better, behavioral health, ocular health, dermatology. These are all practice guidelines that have been put together by the members of the ATA and really codifying, if you will, how to do this correctly. And so I encourage your listeners to tap into those resources, and I encourage them to engage in the conversations with us. We have a lot of things that we're doing. We are very eager to convene people, because I think that the more we stick together in this, the more likely we're going to be successful in ensuring that every American gets care where and when they need it, and that when they do, they know it's safe, effective, and appropriate. And that's really what we're trying to do.
Well, Anne, that's really inspiring and powerful, and this conversation has been really great. I want to thank you so much for your time today and sharing your great expertise. Thanks.
Thank you so much, Chris. It was a pleasure.